Good morning, everybody, and thanks for inviting me along. Fantastic turnout, and it looks like it's going to be a great program. My name's Adele Melton. I'm one of the gastroenterologists at Middlemore, and I'm clinical lead of bowel screening down there. So I'll try and rattle through quickly in 10 minutes a summary of bowel cancer, bowel polyps, and the screening program, and then hopefully we have a few minutes for questions at the end. So there's where I work, and as I mentioned, we'll cover cancer, polyps in the screening program, and if we've got time, maybe a few cases. So obviously cancer, detectable, treatable and beatable, key things to remember. Now, first and foremost, why is bowel cancer important and why do we care about it? Well, about 3,000 odd New Zealanders are diagnosed a year and 1,200 will die. So I'm sure we all have patients who've had bowel cancer or who are going to be diagnosed or might know family members or friends. It's the second leading cause of cancer death in New Zealand and it affects people of all ages. This global phenomenon of early onset colorectal cancer is becoming a big thing. By early onset, I mean under the age of 50, so it's also important to remember in the younger demographic too. So looking at it as us in New Zealand compared to the rest of the world, so this is the incidence, and as you can see, New Zealand down in the bottom red circle, darker blue, so higher incidence per 100,000, and then also high incidence in terms of mortality, so darker red colour. In terms of what the other cancers are, so this is the Globocan data. So essentially they take all of the cancer cases, including non-melanoma skin cancers, and rank them in terms of their incidence, mortality, and where they live demographically. And as you can see, these are from a large number of countries. So colorectum's the third most common throughout the world, and then the second most common in terms of mortality. So this is the predicted data for 2024 based on 2022 stats. So if you want to look at it in a slightly different way, so gets the bronze medal for incidence and silver medal for mortality, which is not a good place to be at. So if you look at it broken down into men and women, so you can see the cohort of New Zealand and Australia, so for men is the blue bar and women is the purple bar, and then separately looking at rectum, men the blue bar again and women the purple bar again, so not a good place to be at. What do all these people have in common? Bowel cancer is the answer. So quite a few Kiwis down there, Di Henwood, Dean Barker, Sir Richard Hadley, and then obviously a few other famous movie stars. The colon, just to refresh everybody's memory, so 1.5 to 2 metres long, jammed all inside your abdomen. You've got the cecum round here, ascending, transverse, descending, sigmoid and rectum. What a great organ. Does all the work for you. Amazing waste disposal unit. Polyps. So we'll jump onto that now. So obviously they start as an overgrowth of cells and then get bigger with time and then have the potential of turning into a cancer, whether it's a cancer within a polyp or a fully invasive cancer. In terms of how we describe them, so you can look at describing them as to what they look like endoscopically, so at the time of the colonoscopy. So we either would sort of group them into either sessile, in which case they're flat or they have a dome-like appearance, or pedunculated, which essentially means they look like a mushroom on a stalk. You can also break them down into what they look like under the microscope, so the histological findings. So I've just listed the most common ones there. In terms of what they look like under the microscope, so tubular adenoma you can think of as the garden variety type polyp. It's the most common one that we find. If you were to zoom in on that image, it looks like a whole load of test tubes all lined up. And the bigger they are, the higher the risk of cancer. Next one down is the villus adenoma. So with the eye of faith, you can probably see it's kind of like finger-like projections or a leaf-like pattern. They're a slightly higher risk of cancer. And then tubular villus essentially is a mixture of the two above. Then we've got the serrated adenomas, which can be broken down into sessile serrated adenoma or traditional serrated adenoma. So they essentially look like a serrated-edged knife under the microscope. They have a higher risk of cancer. Hyperplastic polyps you can just think of as benign, so no cancer risk. They're, again, pretty common. We tend to see them in the rectum and in the sigmoid. And then inflammatory polyps we often find in the setting of inflammatory bowel disease as pseudopolyps, or we can also see them in the setting of mucosal prolapse. Surveillance guidelines. So these are the guidelines that were updated in 2020. I wouldn't expect GPs or practice nurses or anyone in the audience to have to interpret this. This is what a gastroenterologist would interpret based on what we find and based on what the histology finds, and that's how we would then make our recommendations. So essentially, if we found a whole load of polyps, then we might say repeat in 1 year. As of 2020, when these guidelines came out, this was the new add-on portion, the green part on the end, which is 10 years or participating in the bowel screening program. So if someone, for example, was 50 and they just had one tubular adenoma, then it would be 10 years' time, so when they turn 60, or the bowel screening program. Why would we deviate away from these guidelines? So if you saw a recommendation that was slightly different to what it would be based on this, it might be because the bowel prep wasn't great, or it might be because we're concerned about the polyps that we've taken off, or it might be that there's something else that we're a little bit worried about. So this is just a sort of general framework, but there might be, other factors at play. The bowel screening program, I'm sure we're all familiar with this now. You've seen the ads around. This is the website, so breast screening, cervical screening, and you can click on the green one for bowel screening, which is timetoscreen.nz. So it's got all the details and information there. We all know about the pilot program, and it's now been rolled out nationally, so currently age 60 to 74. They're doing a trial of the lower age bracket down to 50 in Māori and Pacific and Tairāwhiti and Waikato. We were promised that it was going to be rolled out nationwide, but it's yet to happen. So as you can see here for Auckland DHB from November 2020, from me at Counties, it's from July 2018, and from Waitemata from January 2018. I'm sure you're all familiar with the pathway, so essentially they get sent the kit, return it. If it comes back positive, they get invited to have a colonoscopy or a CTC. If it's negative, they go back and get sent another kit, 2 years, so on and so forth. Who doesn't need to do the test? So if they've got colon cancer, if they've had a colonoscopy recently, if they've got ulcerative colitis or Crohn's disease, if they no longer have a large bowel. Mind you, in saying this, I think the instructions people often don't read and they'll just do the kit. I know we had one at Middlemore where the kit was returned, and it was actually of a patient that had passed away several months earlier, and it was the wife who had done her husband's kit, and it came back positive, so then we had to go down the route of investigating that. People don't necessarily read the information on it, but that's okay, we deal with what we're given. This is the kit that they do at home. In terms of what we're finding, so lots of pathology. This here is a bowel cancer, that's diverticular disease. Down the bottom is ulcerative colitis, that's a pedunculated polyp. Above that, some ulcers in the small bowel. That's a little inflammatory polyp. That's sigmoid-associated diverticulitis. There's another polyp, there's angioectasia, there's some hemorrhoids. So lots of pathology out there. In terms of data and stats, what are we picking up? So this is the Middlemore data. So as you can see, we've picked up 258 cancers as of the end of August. I can tell you there's been 2 more this month. We've done 3,698 colons, 280 CTCs, and the average number of pots is written there because every single sample that gets sent off gets sent in a different pot. So if there's an average of 4, it kind of means we're finding about 4 polyps or four things to take samples of. What about nationwide? So I know it's a slightly different catchment in terms of 2017 till July 2020, but 2 million kits sent out, 1.1 million returned, 42,000 positive, and we've done 36,000 odd colonoscopies and 2,500 cancers diagnosed. Important to note that about 1/3 of those are early stage cancers, which is a significant thing because we know that earlier it's picked up, the better the prognosis. So just to refresh our memory in terms of staging, so the T, N, M staging, so N obviously if lymph nodes, M if there's metastases. And this is comparing symptomatic presentation of bowel cancer. So I'm conscious that this data is a little bit old now, the Piper study, which was done in New Zealand between 2007 and 2008. So you can see there only 12% were picked up at a stage 1 cancer, through to those having the first screen, it was more like 34%, and then subsequent screens, 29%. So well worthwhile our patients doing. Participation rates, what I would say is could be a lot better, and there's lots of work going into this field in terms of advertising and trying to get community buy-in from various places. Do we have enough time for cases, or I can whip through 2 quick cases? Okay, 2 minutes. Right, first one. This is a lady that 72, has a background of glaucoma, right shoulder joint replacement, previous Graves' disease. She returned a positive fit. She came onto my list for a colonoscopy. Of note, her husband actually had serrated polyposis syndrome, and she said, oh, he's been through this so many times, finally it's my turn. Lo and behold, bowel cancer at the hepatic flexure. She's also got sigmoid diverticular disease and then a few other polyps. In terms of the histology, so as I mentioned, every pot gets sent, or every sample that we take gets sent in a different pot. So she's got sessile serrated lesions, she's got some with dysplasia, which are high risk. She's got cancer there in that 4th specimen, and then a hyperplastic polyp down in the sigmoid. So that's her CT scan. Sorry, it's not the best image. So left on this side, right on this side, this is the colon going across there. So she's gone on to have a laparoscopic right hemicolectomy, which has come back as T3N0M0 disease, which is fantastic, so early stage cancer, no lymph nodes involved. They did find an incidental appendiceal mucinous neoplasm, but they also think she's got serrated polyposis syndrome. Maybe gone out in sympathy for her husband, I'm not sure. Number 2, 62-year-old Samoan man, also one of my patients. So he had bypass surgery for severe 3-vessel disease and critical left main stem back in April. Dyslipidemia, recent ex-smoker, had impaired glucose tolerance, returned a positive fit. But of note, he was still on ticagrelor, as per his cardiologist, and on aspirin. So given that he was on these dual antiplatelet therapy, we arranged for a CT colonography. So on this stage, with this CT scan, he's lying prone, so buttocks at the top there and femoral head there. And you can probably appreciate what they do with a CT colonography, they inflate the bowel with gas, and what you're looking at is something bulging into the lumen down low in the rectum. So he came up directly from his CT colonography for a colonoscopy, and this is what we found. So a rectal cancer. That big black thing is the camera, and I'm bending it round, retroflexing in the rectum, and the biopsies came back as adenocarcinoma. So he's gone on to have a low anterior resection. He's T1N1, unfortunately had one lymph node involved, but is recovering well.